Ever had reflux? Hi, it's Dr. Fan here to talk about hiatus hernias today. One of the few hernias that you can't see sticking out of your body anywhere. The others are in your brain, but coning is a discussion for another day. Hiatus hernias occur when the stomach and sometimes other abdominal organs pop through the diaphragmatic opening of the esophagus and end up in the chest. Normal physiological movements of the stomach can be expected even up to 2 centimeters into the chest, but anything more than that is considered a hiatus hernia. To understand hiatus hernias, it is important to understand reflux and the normal anatomical mechanisms that prevent reflux. The following features are all in place to allow passage of food down into the stomach, but not allow food and gastric contents back up into the esophagus. 1. The lower esophageal sphincter. This involves a ring of muscle fibers at the junction of the esophagus and stomach that act like a valve. The distal end of the lower esophageal junction joins onto the stomach, and is also known as the gastroesophageal junction. This also correlates with the squamo-columnar junction on the mucosal aspect of the esophagus. 2. The diaphragmatic crura. The two edges of the left and right diaphragm are normally located at the level of the lower esophageal sphincter, and further act as a muscular seal to close the esophagus from the stomach. 3. The angle of Hiss. This is the angle at which the esophagus enters the stomach. It normally inserts at an oblique angle. 4. The intra-abdominal esophagus. There is normally 2 to 3 centimeters of esophagus located inside the abdomen, which in combination with the angle of Hiss means the distal esophageal opening closes with gastric contractions to reduce reflux. 5. The phrenoesophageal ligaments. These ligaments join the diaphragm to the distal esophagus and keep the previously described structures in their correct anatomical positions. Disruptions to these anti-reflux mechanisms can lead to the development of hiatus hernias. They can be classified into 4 different types. Type 1 is also known as a sliding hernia. This is by far the most common type and represents around 95% of all hiatus hernias. It occurs when the gastroesophageal junction moves up above the diaphragm while the fundus of the stomach remains in its usual position below the diaphragm. Type 2 is also known as a paraesophageal hernia. This is rare and represents less than 1% of all hiatus hernias. It involves a defect in the phrenoesophageal membrane with the gastric fundus herniating through, but the gastroesophageal junction remains in its fixed position, fixed by the pre-aortic fascia and the median arcuate ligaments. Type 3 involves both the fundus and gastroesophageal junctions herniating through the phrenoesophageal membrane. The fundus lies above the gastroesophageal junction. It represents about 4% of all hiatus hernias. Type 4 involves a type 3 hiatus hernia with another abdominal organ herniating through to the chest. It represents less than 1% of all hiatus hernias. There are a number of contributing factors to developing a hiatus hernia, including congenital defects, trauma, and previous surgery around the region of the hiatus. Type 1 hiatus hernias involve a progressive disruption to the phrenoesophageal ligaments, which disrupts the position of the gastroesophageal sphincter. The gastroesophageal sphincter moves up into the chest and creates a pouch of stomach beneath it, closed by the gastroesophageal sphincter on top and the diaphragmatic crura below. This reduces the effectiveness of anti-reflux mechanisms, and gastric acid refluxes first into the pouch and then into the esophagus. Types 2 to 4 hiatus hernias involve the disruption of the gastrocolic ligaments, which allow the gastric fundus to move out of its position past the diaphragm and up into this chest. The resulting stomach in the median sternum again disrupts the anti-reflux mechanisms. How do hiatus hernias present? The majority of hiatus hernias are small and asymptomatic. When they do cause symptoms, type 1 hiatus hernias tend to present with reflux, dysphagia, heartburn, and regurgitation, while types 2, 3, and 4 hiatus hernias tend to cause pain, nausea, and the feeling of fullness. They can also present with complications including severe pain and vomiting from a gastric volvulus, which is a surgical emergency, bleeding due to Cameron's lesions or erosions at the hiatus hernia, and respiratory distress due to a giant hiatus hernia mechanically displacing lung volume. Because hiatus hernias are dynamic structures that move with swallow, it is best diagnosed with direct visualization during an upper endoscopy. A separation of the squamocolumnar junction from the diaphragmatic impression of greater than 2 centimeters is diagnostic of a hiatus hernia. This may be better visualized on retroflexion during endoscopy. A barium swallow involves a series of dynamic X-rays being taken at the esophagus with oral contrast. A hiatus hernia is diagnosed if the lower esophageal sphincter is measured to be 2 centimeters above the diaphragmatic hiatus. Treatment options depend on the type of hiatus hernia. Small type 1 hiatus hernias can be observed and treated with proton pump inhibitors to reduce symptoms. An elective operative repair should be considered if symptoms persist despite optimal medical therapy. Type 2 to 4 hiatus hernias have a 2% risk per year of developing a complication that requires emergency surgery. Elective repair operations should be considered up front after considering patient preferences and comorbidities. Any complications such as severe bleeding, volvulus, obstruction, strangulation, and perforation will require an emergency operation. The aim of elective operations is to restore the anti-reflux mechanisms described earlier. This involves reducing the hiatus hernia, restoring 2 to 3 centimeters of intra-abdominal esophagus, recreating the angle of His, repair of the diaphragmatic crura, and reinforcing the lower esophageal sphincter. This typically involves a fundoplication with crura repair, of which there are many variants. But that is a discussion for another day. Well, I hope that you have learned something new. Please watch this again to reinforce your learnings because repetition is a key part of learning. And please remember to like, subscribe, share, and comment for more videos.